Okay, last time we left off with foot and ankle. And this time we are going to start with the lower leg, the knee, and the femur. Okay, so let's take a look at the tibia and fibula, or as what you will come to call it is the tib-fib. Okay. You can see right here that this is the tibia. This is what we call the shin bone. Okay. This is the stronger of the two because this is a weight-bearing bone. In other words, everything above here, weight is put onto this bone. None of it is put onto the fibula. Okay, none of it is put onto the fibula. So if you break your fibula, you can probably still walk unless it's sticking out or whatever, okay? But it's not that big of a deal. Sometimes even on the fibula, they can do bone grafts and take out a chunk from maybe here to here. And you'll see this and you'll see this, and there's nothing here. And it's totally fine. Okay. So let's talk about the parts of the tibia first. Okay. Now we talked about this part before. Okay. So if you remember, these were the malleoli. Do you remember that? These are the malleoli. This is the medial malleolus. This is the lateral malleolus. The lateral malleolus, which is on the fibula, is much bigger and longer. Okay, and this right here is the distal tib-fib joint. This up here is the proximal tib-fib joint. Remember, if you Joshua, could you turn your microphone off, please? Thank you. Okay, so let's, since we've already talked about this, let's start with the proximal tibia. But before we do that, let's look at this thing right here. You see this thing I'm kind of drawing on top of? That's the anterior crest. And if you look at it on a real tibia, okay, this one feels a little bit rounded, but it's actually on a newer bone. It's much sharper, literally sharper. Okay, if you feel on the front of your shin bone, okay, the front of your tibia, and move your fingers side to side, do you feel that edge? Need to be doing it. You feel that edge along the front of your tibia. Okay, now that edge is the anterior crest of your tibia. Now, how many of the guys have ever hurt your shin bone? It hurts like the dickens. It really does. It hurts like the dickens. And the reason why it does is because not only did you hurt it from the outside, but you hurt it from the inside, because this is sharp. Okay, let me put this on me. Okay, because this edge right here is pretty sharp. So if you run into something and you hit it, it hurts. It hurts, one, because you hurt it from the outside, but you're also hurting the tissue from the inside because it's very, very sharp. Okay, or it's sharp to me. Okay, so here on the top of the tibia, the proximal tibia, you see we kind of got all these little lumps and things. Okay, right here, this area right here is called the tibial tuberosity. The tibial tuberosity. And on this guy, this is the top of the tibia, the proximal. See this right here? That's the tibial tuberosity. And that is where we have one of the quadriceps tendons come down, and it attaches right here. Okay. And what that does is when you walk, okay, and this muscle contracts, then it helps you bring this back forward. So if you didn't have that attachment here, when you start to walk, you're going to be stuck. You have nothing to bring it forward. Okay, so that tibial tuberosity is very, very important. Sometimes there's a condition in which this starts to come off. Okay, and if this comes off, that means that there's no good attachment for that quadriceps tendon right there. So there's a condition called Osgood-Schlatters. Osgood-Schlatters. It's a funny name, but it is what it is. Osgood-Schlatters disease. Okay, and that's when this starts to come off. People with this, and there are different degrees of how problematic it is. Some people, when they walk, they have to walk straight-legged. Okay, the whole leg has to be straight. They can't bend at the knee because they won't be able to unbend it. Okay, so this is called the tibial tuberosity here. Okay, right here on top, see this right here? These are called the tibial plateaus. The tibial plateaus. Okay, and this right here, those are the tibial plateaus. These are what are going to articulate with, this is the distal femur, and these two things will come together like this to make the knee joint. Okay, so this articulates with the tibial plateau here. So that's an articular surface right there. Now, in between the tibial plateau, we have what's called the tibial spine. It looks like that, okay? And this one's been kind of worn off. You can kind of see it right there. Do you see that? There's like two little humps, okay? We can either call that the tibial spine or the medial and lateral intercondyloid tubercles, okay? Or the intercondyloid, the whole thing would be the intercondyloid eminence, or the whole thing would be called the tibial spine, or each of these would be called the medial or the lateral intercondyloid tubercle, okay? I will probably refer to them as the tibial spine right here, okay? Any questions so far, guys? Let me get you guys back up here. No questions? No? Okay. So because I'm going to put it on me so that you guys can see the bones, make sure you say something if you have a question, okay? So I can hear you. Okay. Now, this part right here, this right here, and this part right here are called the condyles of the tibia. So that would be this chunk and this chunk, okay? This is the lateral chunk or the lateral condyle of the tibia. This would be the medial condyle of the tibia. Now, if you noticed, I looked down because I needed to see if it was lateral or medial. This is the lateral malleolus, so that I know that this is the lateral condyle. Okay, this is the medial condyle. And on top of the condyles, we have the articular surfaces that we call the tibial plateaus. Okay, now on the femur, I mentioned we have condyles. So we have condyles on the femur and we have condyles on the tibia. So we have to, when we talk about condyles, we have to say where they are. So this is the lateral medial condyle of the tibia. This is the lateral and medial condyle of the femur. Okay. Let me see, was there anything else on here? Yeah, let's go to the fibula. Okay. Now this is the fibula here. Okay. This is the fibula right here. Now, this part can be called the proximal fibula. It can be called the head of the fibula. And We can also call this the apex. Apex means it comes to a point. We can also call it the apex of the fibula. So if you're not exactly sure where they're pointing, any of those three will work. Okay. Okay. Okay, let's look at a side view here. Okay. Here you can see that we have an angle going from the anterior to the posterior of about 10 to 20 degrees. Now, that number, depending on your source, we're going to go ahead and go with this number, but depending on your source, that number can change a bit. Okay, so 10 to 20 degrees of posterior caudal angle. Okay, again, here is the head, and under every head's a neck, and this would be the apex right here. Okay, we can also call this the styloid process of the proximal femur. Okay, styloid process or apex of the proximal, not femur, fibula. Okay, if I say something stupid, you guys say something. So this is the fibula. Remember I told you the ula is the diminutive. So that's why this will always be the smaller one, because it's got ula on the end. Okay. And again, that the angle that the tibial plateau takes is 10 to 20 degrees caudal. Okay. Okay, the femur, which is what I'm holding right here. Okay, but let's just take a look at it. We're mostly distal, but again, the guy doesn't know how to draw. He makes it look like that. You got some bone melting right here. That does not exist. If you look right here, you don't see anything that looks like the bone is melting off. Okay, so this does not exist. But this would be the lateral condyle, the whole thing, the lateral condyle, and then we have a lateral epicondyle and a medial epicondyle. Okay. We also have the patella. The patella is a quite large, or the largest sesamoid bone that you have on the body. Okay. The patella, we said, is a sesamoid, so it's embedded in the tendon. Okay, so you've got the quadriceps up here, and then that tendon goes like this, and then it attaches to that tibial tuberosity we talked about on the tibia. But this is embedded in that. Okay. Now, when you center for a knee, okay, this is the patella right here. Okay, it's shaped like this, and it's about this size. Okay, some a little bit bigger. This would be the base, and this would be the apex. So it's kind of like a downward pointing arrow. It always points down. It always points down. Now, when you center for a knee, you have to palpate the patella, because you're going to center a ½ inch below the apex of the patella. So if this is the apex of the patella right here, about ½ inch below is going to be right here. And this is where you're going to center the CR, because that's exactly where your knee joint is going to be, right ½ inch below the apex of the patella. Okay, because when you're doing a joint, you want to center to the joint. Okay, now also right here, the femur is the longest and strongest bone. Now this is a little one, so typically if you have a bigger one, this is going to be even bigger and stronger. Okay, it's a very strong bone. As a matter of fact, both femurs and tibias were used for weapons in early days of man. Okay, so if you break your femur, or sometimes they'll say you broke your hip, but you break it right here. It's really the proximal femur. It's a big deal. It's a really big deal. This thing is so strong that if you do break it, remember, this is in the middle of a bunch of strong muscles. Okay, think about, okay, let me just give you guys something to think about, okay? Okay, let me find it. Oops. Okay, he's my guy. So let's look at some images of Arnold Schwarzenegger here. Okay, this is what I wanted. Quite literally. Okay, look at his thighs. Do you see those muscles? Okay, these muscles are really, really strong. Now, if he was to break his femur, okay, what would happen is that these muscles will contract. And those muscles are so strong that that femur that broke is going to go like this. And it may take quite a while in traction for them to be able to pull that apart to set it. Okay, who is this guy right here? I wonder if that's him. What is his name? My daughter's coach at school, he was a is it Mr. World or Mr. Olympia that Arnold was in? He was friends with the coach that was a Mr. Olympia. And he was a tiny little guy, kind of looked like this. So that's why I was thinking it might have been him. But yeah, very, very, very muscular. But again, back to these muscles. Let me look at you guys. Okay, those muscles are so strong that when this breaks, those muscles contract. And sometimes, even if you're not strong, it can take two people on this end, two people on this end to try and pull them apart during surgery. Okay. So sometimes before they can even fix something like that, they have to put them in traction for quite a while because you can't get enough people to pull it to set it. Okay. And lots of times they have to go ahead and pin femurs just to make sure that they stay there and the muscles don't make it do this again. Okay. All right. Any questions on that? No? Has anybody broken a femur before? No, because that's a big deal. That's a really big deal to break a femur. Okay. Sorry, he doesn't want to go away. Just a minute. Here we go. Okay, so let's go back to this. Okay, so here we're looking at the femur, and we see that it's kind of at an angle. Okay, so from the straight and narrow, it's about 5 to 15 degrees. That mostly depends on if you're male or female. Okay. Now, this angle is what happened to our femurs and our pelvis when we became bipedal. Okay, because it gives us more stability. Okay, so if you try and walk, usually if I was in class, I would show you, if you try and walk with your femur straight down and your knees will be separated, okay? When you try to walk, not only are you going to look goofy, but you're not going to be able to run for your life, okay? So this was a matter of survival that our knees or our femurs angled in like this. And it puts the knees so that they're closer together to give the body more stability. Okay, so this angle gives us much more stability. Okay, I mean, you know, maybe this person can run really, really fast. Okay, but do you think a chimp can run that fast? No. Now, if they're on their all fours, they probably could, but not bipedally because they're like this. So let me, I went and looked some stuff up today. Just a second, let me minimize this or get this out of the way for a second. Okay, let's look at this one first. Sorry. You guys can see this? I have to hear you, yes?
Yes.
Okay. Okay, so here we have a chimp and here we have a human. Now, what this center line here is the center of gravity, okay? The center of gravity. So on a chimp, there is a higher center of gravity, and so because ours is in terms of the entire body, ours is lower, and it allows us to be more stable when we walk on two legs. Okay. Also notice, remember when we talked about the curves of the spine? Remember that? Okay. Look at the curve on this guy. Doesn't have much of a lordotic curvature down here, do they? Okay. So when they try to walk upright, it's very cumbersome for them and they don't have as good a balance. This allows us to have more balance and have a higher center of gravity by having the curves in the spine. Okay. This is the spine for people, or not for people, for animals that walk on all four. Okay. Now let me see what else. Come on. Okay. Just a second. Okay, so you can see right here. You can see right here. This is us. This is an Australopithecine. This is one of the first bipedal human species right here. And this right here is a chimp. Do you see the angle on the leg between the chimp and us? Okay, now it makes a difference. So with having straight femurs and a more straight spine, let me show you what I also looked up. Let me see. Let me find it. I just had it. Here we go. Okay, so let's look at, some of these are monkeys, some of these are apes. If we walk like that, whoops, just a second. If we walk like that, we'd look pretty funny, wouldn't we? Okay, yes, they can walk on 2 feet, but not on 2 legs, but not very far. It takes a lot of energy for them to walk like that. But that dude knows what he's doing. He's cool. So yeah, they're walking on 2, but they're not going very fast and they can't go very far. Okay. And this is a show off. So, but anyway, my point is that because we've evolved more than these guys have in terms of bipedalism, okay? Not that we're more evolved, they're evolved for what they are. We're evolved for what we are. We are not the greater species. What all I mean is that is that we've evolved to be bipedal. And so we are more stable with this angle right here. Okay, it allows us to walk upright using less energy, and it also makes us more stable. Okay. Let me see, do I have anything else? Okay, so here we're looking at another one. This would be the angle. You can see right here when you have the condyles of the femur on a flat surface. So this would be a chimp. This would be a human, and this is Lucy. Who's Lucy? Australopithecus afarensis. She's one of the earliest. They have found somebody earlier than her species of humans, but you can see that we have a real big angle on here versus from a chimp. Okay, so she was the first one they think to have come down, not her specifically, but her species to have come down from the trees and started to walk the plains. Okay, and she was very, very tiny. She was barely over 3 feet tall. Okay, let me see. And this one, okay, here we can also look at the pelvi. Okay, this is from a chimp and this is from a human. Okay, so the way our pelvis is and the angle that we have right here, it allows us to walk upright. Okay, so this elongated hip bone or hip bones on this chimp is more for walking on all fours along with the straight femurs. Okay. Now, I said earlier that if you try to walk with your legs straight out here, okay, number one, you get tired. Number two, you can't run very fast. And number three, you won't be very stable because your knees have to be together for you to be stable. Okay. So that's why we look like what we look like. Okay. And in the next time we meet, we will talk about the pelvises and the difference between the male and female pelvis. Okay. The female pelvis is more wide, and to be able to keep the knees close together, this has to be at a greater angle than it would in a male. Okay. Now, not on everybody. Some males have more of an angle than a female, but for the most part, females have more of an angle on their femurs than males do. Okay. I think that was all that I had on that one. Oh, I'm lying. Just a minute. What everybody said about the bird. Okay. Oh yeah, I already did this one. Okay. All right, let's go back to this. Okay, any questions, you guys? No? Okay, so again, this is the proximal tib fib. This is the proximal tib fib right here. This is the distal tib fib. This is the lateral malleolus. Remember, the lateral malleolus comes down way more than the medial malleolus does. Okay. Okay. Okay, did we talk about this one? Yeah, we did. Okay. And remember that the apex of the patella is about 1/2 inch. You're going to center at the apex and then go down 1/2 inch. And that's where the knee joint will be. Okay. The space between the fibia and the tibia and the femur. Was this the next one? Sorry, guys. Yeah. This is it. Okay. All right. You know what I didn't do is I didn't talk about the top as long as we're doing it. Let's just talk about the top right here. Okay. This rounded part right here is called the head of the femur, the head of the femur. And it really is, just a second, let me get this bigger. Okay, and it really is rounded right here, okay? You can see it's rounded. And then on this end, which I don't think you can see, a second. Okay, do you see this right here? Okay. That is going to attach to a ligament that helps keep it in its socket. We'll talk about that when we get into the pelvis, okay? And you can see right here, okay? It's a little bit rough. It needs to be rough so it can attach to that ligament, okay? So this is the head of the femur. This right here is the neck of the femur, okay? This is the neck, okay? We're looking, right now, we're looking at the front, okay? This is the greater trochanter. This is the lesser trochanter. We talked about those before, okay? Now, in between on the front, you see this like a little small set of mountains right here, okay? This is called the intertrochanteric line. Now, that one is not that important. Most people don't even refer to that. I do, okay? But this is the intertrochanteric line. It sounds like a big word, but it just means between the trochanters, intertrochanteric, okay? Now, this is intertrochanteric line. Now, this one, however, you do need to know. This looks like a higher mountain range, doesn't it? This is the intertrochanteric crest. You do have to know this one between the greater trochanter and the lesser trochanter. And this is posterior, the intertrochanteric crest. So again, head, neck, greater trochanter, lesser trochanter, intertrochanteric crest. Okay. Any questions, guys? No? Okay. Now, all of that anatomy really is important, okay? I already did that one. Okay, we are now looking at the back or the posterior, which is what I just showed you a second ago. Okay, this is posterior. Again, that's the intertrochanteric line. But let's look at the bottom posteriorly. Okay, so posteriorly we have, remember we're looking posterior, I'm sorry. Okay, you're looking posterior, I'm looking anterior. So this is the posterior here. Okay, so if you look down here, you can see the condyles. Now, how do we know which one is which? Well, if you kind of look up here, okay, unless your hips are outside your pelvis, this must be medial. Okay, so this is the medial condyle, and this is the lateral condyle of the femur. Okay, now in between, see where I'm fitting my finger here? In between, this is called the intercondylar fossa or notch. And if you look, see it right there? Okay, that's the intercondylar fossa or notch. Okay, it's in between those condyles. Okay. Now, on my x-rays of my knee, one of these condyles looks like it's broken completely off. That's how bad off my knee is. But anyway, I didn't know that they would break off, but mine did. But anyway, so this is anterior, this is posterior, this is the intercondylar fossa or intercondylar notch. Okay, intercondylar meaning it's between the condyles, Okay, now again, we're looking at it posteriorly here because that's where these guys stick up posteriorly. And if you see right here, there's a little flat surface. It's flat and triangular shape right here. Okay, this is called the popliteal surface. Popliteal surface. Anytime you hear the word popliteal, it has to do with the back of the knee. Okay, popliteal. So we can have this popliteal surface, we have popliteal muscles, we have popliteal ligaments, we have popliteal nerves, popliteal vessels. Everything back here is called popliteal something, okay? So this is the popliteal surface back here. So if we're looking at the back, okay, if we're looking at the back, okay, I'm not you, okay, you're looking at the back. Okay, so if this is medial, this is lateral, okay? So if this is lateral, this is medial. Now, if you notice right here, remember I told you this is the condyle, this is an epicondyle, but on the epicondyle is also what we call a tubercle. It's really kind of almost the same thing, okay? And this is called the adductor tubercle because remember, this is medial, okay? So if your leg goes out like this, when the muscle that's attached to this adductor tubercle right here, when it contracts, it's going to pull up your whole leg back in, okay? Because it's going to adduct. It's going to add back. So this would be the adductor on the medial side of the femur, okay? So did I talk about all of these? Just a second. Okay, so again, we're looking at the posterior, and you've got the popliteal surface, you've got the medial condyle, medial epicondyle, the adductor tubercle on that, intercondylar fossa or notch. We have the lateral condyle and the lateral epicondyle, okay? Now, also note that the knee goes inwards 5 to 7 degrees. Okay, now, so it goes from lateral to medial 5 to 7 degrees. Now, it's more angled. We have a higher degree here on females because on females, remember, let me go further back. Okay, because remember, they're angled like this, okay? So that this is going to have more of an angle. This is going to have more of an angle because their whole leg is angled more, which is one of the reasons why females typically have problems with this part, the medial part of their knee, because the whole thing kind of goes, just a minute, I have to be dramatic. The whole thing kind of goes like this, and that's how they get their injuries. Okay. And it's because we have an angle on the femur, which means we have an angle on the intercondylar line here. And so it makes it less stable for females. Okay. Questions, guys? No? Okay. Whoops. That's not what I wanted. Just a second. Next. Okay. Now we're just looking at the knee itself. Okay. Again, he doesn't know how to draw. So this looks like it sinks in. It doesn't sink in. This sticks out. Okay. He kind of has his perspective a little bit backward. This sticks out. And also on the patella, you see on this side right here, he makes it look like it sinks in. Like if you turned it this way, you could like eat cereal out of it. No, it's not shaped like that. This is pretty much, there's very, 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 very tiny curve right there, but it's mostly flat. It's not this. Okay. So this patella here, and notice right here, okay? If we're looking at this side, does that look like that's going to sink in? No, as a matter of fact, it doesn't quite go out this far, but it's kind of more like this, okay? But it certainly doesn't sink in, and that's what he drew right here, okay? So this space between the patella and the distal femur is called the patellofemoral joint, the patellofemoral joint. So yes, there's a joint between your kneecap and your femur. Okay, the patellofemoral joint. Now, on this, okay, on this bone, and we're going to look at it right here. This is what we're going to look at right here. This is the patellar surface. Okay, this does sink in a little bit. This can be called the patellar surface, or the intercondylar sulcus, or the trochlear groove. Now, do you guys remember what trochlea means? Because we had one in the elbow. It means pulley. It means pulley, okay? So a pulley system gives more strength than what would be there if you didn't have the pulley system, okay? Okay, so again, this is the patellar surface. That would be right here, but we're looking at it from the side. This is the patellar surface, or the intercondylar, meaning between the condyles, sulcus, or the trochlear groove, okay? Now, this is all white because it's slick, because remember I told you this is going to articulate with tibial plateaus to form the knee joint, okay? So this is what makes the knee joint right here, okay? It's like that, okay? So these are the condyles, and they'll be slick. Now, this again is the intercondylar fossa or notch. That would be this right here. That is different than this right here. This is the trochlear groove, or the intercondylar sulcus, or patellar surface, okay? But this right here is the intercondylar fossa or notch, okay? So next time you guys are in class, you guys can pass these around so you can kind of play with them, okay? What is this called right here? Do you remember? It's the tibial tuberosity. Okay, the tibial tuberosity. One of the, I've told you before, I have a very high pain tolerance. But one of the biggest pains I've ever had was I was camping, and I went into the tent, and I was going to get something off the floor. So I just fell to my knees, not a big deal. Okay, I was young. And right under my tibial tuberosity, when I fell to my knees, was a teensy tiny little rock. I mean, it was tiny. It was less than the size of a pea. Well, I hit it just right on the tibial tuberosity, and I have never felt such pain in my life. It hurt. So you can feel it on the front of your knee. So if you find the apex of your patella and go down about this far, I guess about 1.5 inches, you should feel a little lump right there on the front. Do you feel that? It's on the tibia, okay? That's the tibial tuberosity, and that's what the quadriceps femoris tendon attaches to. And then when your quadriceps contract, it pulls your leg forward so you can take another step. Otherwise, you're stuck, okay? I know that they have fixed them. I've seen some x-rays where they have put screws through the tendon, through the tibial tuberosity to hold that tendon in place, okay? And I can't imagine how much that hurts, because that tibial tuberosity hurt like the dickens, okay? Okay. Okay, now we're looking at a patella. Again, it doesn't sink in on this side. Okay, it doesn't sink in. So this is the anterior surface. This is rough. Now, it's rough because remember, I told you that this is embedded in a tendon. Okay, so part of it is inside this tendon here. So this has to be rough so that this can attach to it and stay attached. But the inside is smooth. The inside is smooth. So why does the inside have to be smooth? Okay, because they probably should have drawn this straight, but when you bend this thing moves. Okay, as a matter of fact, if you a second. Okay, if you put your leg out in front of you, still have it on the floor, okay, but no bend in your knee, and totally chill so that your leg is totally relaxed. Okay, you can tell it's relaxed because if you put your hand on your patella can move all over the front of your knee. How many of you are relaxed enough to move it? Elena, do you have it moving? Okay, it truly has to be relaxed for it to do that. Okay, and as a matter of fact, sometimes that patella is so mobile, and you watch somebody do this with their patella, you want to throw up because it doesn't look normal, but it is. It's supposed to be mobile. That's how it can move up and down when you bend and straighten your leg. Okay, and it goes along that patellar surface in the front. Okay, so has anybody ever had physical therapy on your knee?
I have.
Okay, did they ever check for your patellar movement?
I would say yes, maybe, because I had ACL reconstruction with my patellar tendon.
Okay, then they would have checked for movement of the patella. Okay, and that's one thing that they usually check every single time, especially post-surgery, because they don't want that to become stiff and stuck, or you won't be able to walk correctly. Okay, but yeah, so they'll just make sure that they're not going to force it, because they're going to make sure your leg is relaxed. And once it's relaxed, and straight, that patella will become mobile. You guys try tonight when you're sitting on the bed, just relax your entire leg, just totally relax it, and then move your patella around. Okay, and if it moves around a lot, you might throw up. But I mean, because it seems weird. Okay, but that's totally normal. That's healthy, and they want to make sure that it stays normal so you don't have a stuck knee. Okay, I don't think stuck is a medical word, but that's exactly what it is. Okay. Okay. Who was telling me about your patella? Was you, Melissa?
Yes.
Was that because of sports?
Yes, basketball.
Yeah, those sports. You guys need to be lazy. You'll be more safe. You'll be more safe. I'm sorry, but it's usually sports that destroys people's knees. Okay, I mean, yes, because you're female sometimes, but that makes you more susceptible to those injuries. Okay, I know that there are some basketball coaches who coach women's teams now who are starting to learn about certain exercise sizes for the women to do to keep them from injuring their knees. Okay, I read there was one story there. This one team was about to go to state, I think it was, and all but one of its starter females was out with knee surgery. And it's very, very, very common. Okay, especially especially if you have contact sports, and basketball is a contact sport. Okay, not supposed to be, but it is. Okay, all right. Okay, any questions on the patella? Okay, remember your patella is mobile. Okay, remember back here is the popliteal surface, the popliteal surface. Okay, and we said this is the base and this is the apex. This is rough so that the tendon can hold on to it. This is smooth because this is part of a joint. What joint would that be? I know we talked about it. What happened?
The patellofemoral joint.
Yeah, oh, there it is. Okay, yes, I'm sorry. We were right on it. The patellofemoral joint. Yes. Okay. The patellofemoral joint, because it's a joint. So this part has to be slick. Okay. And where do you center for a knee?
Half an inch below the apex.
Perfect. Perfect. Thank you, Zana. Okay. Melissa, what was it you said you injured?
I completely tore my ACL.
You tore your ACL. Okay. Now, what she's talking about, shoot. What she's talking about is this right here, the ACL. This is called the anterior cruciate ligament. This is the posterior cruciate ligament. Okay. Now, what these two ligaments do is they fit in. They fit right in here. Okay, inside of this. So what these ligaments do is they help with front to back stabilization. Front to back stabilization. Okay. Now, these ones on the side here, this is what we call the lateral collateral or fibular collateral. Okay, lateral collateral, LCL, and on the other side would be the medial collateral ligament or the tibial collateral, but I'll call them medial collateral and lateral collateral because it sounds better. But anyway, what these two collaterals do, just like the collaterals in your ankle and in your elbow and in your wrist, they help stabilize the joint side to side. Okay. They help stabilize the joint side to side. Now I had this one replaced. Well, I had something replaced, but I think what he did was he took this and he connected or stapled it right here. Okay. Yeah, really cool. Because I had a problem with side to side stabilization. Okay. But then what happened was now I didn't have anterior posterior stabilization. So he kind of screwed me up on that. But anyway, Melissa, how is your knee?
Oh, it sucks.
Yeah, do you think you might have done better without the surgery?
Well, I wanted to play basketball still, but I also rushed my recovery. I did it in 5 months when I know it takes 6 or longer.
Yeah. Yeah.
And I already know I have arthritis in my knee.
Any injury, you'll end up with it. But I think anytime you have surgery, it makes it worse. I'm sitting in bed after surgery, I'm at home, and I looked it up and it said, you're better off just going with physical therapy than having the surgery. Well, now they tell me, okay, and I totally believe it. My knee is totally destroyed. I mean, doesn't even look like a knee anymore. It's so bad. And I'd originally injured it snow skiing, then I injured it water skiing, and then I slipped. So I injured it 3 times, and so finally after the third one, I had the surgery. But and I also broke my knee. I broke the top of the tibia right under the tibial plateau. It is the widest part of any bone right here, and this is the most difficult one to break, and I broke it right across here. So, but anyway, that's what happens when you're active. You're asking for it. Stay on the couch, okay? Never get up. All right. Let's go back to, I guess it was this one. Okay, so here we have the lateral collateral. On the other side, you can't see it, is the medial collateral. And then this is the anterior cruciate or the ACL. This is the posterior cruciate or the PCL. Now, these are the 4 that are always getting injured, okay? Especially in basketball and football, okay? Now, notice right here, this thing right here, this is called the meniscus, plural menisci, because you have it on both sides, okay? This is like a shock absorber. So without that shock absorber, your knees, you're going to have bone on bone. And pretty soon the bone wears out, okay? So this right here acts as a shock absorber, okay? When do you need a shock absorber? How about just walking, right? Every time you walk, when you run, okay? Runners typically have lots of problems with their knee eventually because of that constant pounding, because remember, all the weight above the knee is gonna hit those little shock absorbers. And those shock absorbers, I'm looking for something that would be the thickness of it. And probably, okay, I've got a, what do you call this? One of those little pads, okay? And this, it's not very thick here, okay? It's only about that thick, okay? And that's only along the edges, okay? So the menisci, and the menisci are, okay, he drew it wrong, okay? Not on this one, but the menisci look like little half moons. They're like this, okay? And you've got one, and they're sitting inside the tibial plateau, okay? They're little half moons here, and then right here would be where the tibial spine is, okay? Or the intercondylar eminence. And then if you looked at it side or from the front, okay, it kind of looks like this, okay? It's kind of wedge shaped. Okay, and you can kind of see it right here. It's a little bit wedge shaped here, okay? So this is if you're looking at it top down, okay? This, you're looking at it from the front, and they're wedge shaped. So they're not that big, and your whole body weight is sitting on this, okay? So these can wear out. They can wear out. They can also get injured, okay? Sometimes they can get torn. Sometimes, okay, let's say this is one of them. Sometimes during an injury, this thing will fold over so that it looks like this, okay? That's not there. It's just, it folds over, okay? That causes a lot of pain. Another one would be, it can be torn. Sometimes they can fix this. Sometimes it can be torn off, and this is kind of floating around. Okay. Again, if it's just torn but it's still on there, sometimes they can fix that. sometimes these things get flattened so that the wedge is kind of like this, almost useless, but they can replace those. They can replace them with cadaver menisci. I have something cadaver in my knee, and I don't remember what. I would have to look. It was either the meniscus or the collaterals. I really don't remember. But anyway, so when this wears down, then you've got bone on bone, and those people have noisy joints. Okay, so they move their joints, and you can hear them as they rub against each other. Okay, and wear down, and that hurts. So anyway, those are called menisci. Okay, and you got them on both sides. Now, I told you that this is embedded in a ligament. Okay, so here we have a ligament, and then it's the muscle up here. Okay, so and then it goes like this, and it's really a bunch of muscles that come together on this tendon right here. This is the quadriceps femoris tendon. The patella is embedded in that. Now, they always make it look, and then they call this the infrapatellar ligament. Okay. This is a ligament because it's going from bone to bone. This is a tendon because it's going from muscle to bone. Now, this in actuality is one structure. Okay. It's just that this part is called a tendon. From here to here, it's called a ligament, but it's really just one structure. Okay. And this is embedded within that one structure. Okay. Does that make sense? Yeah, they always make it sound like it's two different structures. It's not, it's one. Okay. Okay. Okay, now, so this part is called the patellar ligament. Now, underneath this patellar ligament is what we call infrapatellar fat. Okay, and you really kind of need that. I don't know about you, but right under there, that's not very squishy on me. Yeah, if we all had fatty knees, because it would protect them. Okay, has anybody ever fallen on your knees before? Yeah, Melissa, did it hurt? Yeah, okay, anybody else? No? Oh my gosh, you guys are so delicate. Okay, but yeah, when you fall on your knees, it hurts. And the whole idea of this infrapatellar fat is for protection, and there's just not enough of it. Okay. Let me see what else. Any questions on this, guys? No? Okay. Okay, now we're looking at the knee joint, but we're looking at it, okay. This is the knee, okay, but we're looking at it like this, okay, where the femur is like this, but we're looking at it head on like this, okay, with the knee bent. Okay, so this right here would be the patellar surface. What are the other names for the patellar surface? The intercondylar sulcus. And there's one more.
The trochlear groove.
Trochlear groove, beautiful. Okay, because that patella slides along there when the knee gets bent and straightened. Okay. Okay, so here you see the medial collateral, or the MCL. This is the lateral collateral. Notice that the lateral collateral attaches to the fibula. Okay, that's the lateral collateral. These are the menisci. Now, he drew them like they're circles. They're not circles. They're like moon shaped. Okay, so they're sitting in there like this. So you've got a thin edge. Okay, so it should be going like like that. Okay, that's what they look like, not like he drew them, because he makes them look like they're like circles, like they're hamburger patties or something. So this would be the anterior cruciate. This is the posterior cruciate. And again, what are those for?
Stability.
For front to back stability. There you go. And then the collaterals are for side to side stability. Very good. Okay. Okay, so here we're looking top down, okay, on the soft tissue structure. So this would be the ACL, this would be the PCL, this is the medial meniscus, the lateral meniscus, and then on the sides here, which you didn't draw, we would have the medial collateral, the lateral collateral, and they kind of cut this off. So you would see this going all the way across here. This is the fat, okay, and then on top of the fat would be the, what would this be? What is this? That's the patellar ligament, okay? Now, here's the quadriceps femoris tendon. You can see right here, you see how this is? It's really one structure, okay? And you can see like right there. Okay, so from the muscle to the bone and around the bone is the tendon, and then from the patella to the tibial tuberosity is the patellar ligament. Now, on either side of this patellar ligament, we have what are called bursa. Remember we talked about bursa before? These are the infrapatellar bursa. We've got some right here, and I think we have some back here too. But you know, again, they're not that thick and not that protective, okay? Here you see the wedge shape of the menisci, okay? Okay. Any questions on this, guys? No? Okay. You guys don't seem too excited. I like the extremities, I do. Okay. Okay, this is the same one we just saw. Now, this is called a knee arthrogram, in which they have injected into some of the spaces, they have injected a contrast. I'm going to take this one out eventually when I think about it. Because we don't do very many of those anymore, okay? This was a big deal. They usually did this before surgery, but now with CT, you don't really need to kind of do this kind of CT and with MRI, okay, depending on what they're looking for. You don't really need to do this kind of stuff anymore. You see you've got a back here, you've got a little sesamoid back there, okay? But this is the main sesamoid right here. Okay, this is an AP and lateral leg, okay? This is a right leg, as is this, okay? Let's see if we can name some of these structures, okay? So first of all, what is this right here? It's the lateral condyle of the femur. If that's the lateral condyle of the femur, then that makes this one the medial condyle of the femur, okay? And this is the intercondylar sulcus right here, okay? Now, this is the lateral condyle of the tibia, and this is the medial condyle of the tibia. How do I know what's lateral? How do I know what's lateral and what's medial? Anybody? How do I know what's lateral and what's medial?
The fibula is on the lateral side.
Exactly, exactly. The fibula is on the lateral side. So these are laterals, okay? Okay, so this would be the shaft or body of the tibia. Remember, that's the bigger bone, okay? All of this is the head of the fibula. This right here can be called the styloid process of the proximal fibula or the apex. And if this is the head, what is this?
Neck.
The neck. Very good. Very good. Okay, now on this one right here, this is a lateral. What is this little bump right here?
Tibia tuberosity.
The tibial tuberosity. Very good. What is this right here? They've got it outlined right here. That is between the condyles of the tibia, so it would be called the intercondyloid eminence or the tibial spine, okay? Or right and left intercondyloid tubercle. Oops. So right along this right here, this is the head of the fibula, okay? Now down here, and they really didn't outline it properly because it really goes down like this, as I can see it, okay? So this is what? It's the same thing as this right here. What is that?
The lateral malleolus.
It's the lateral malleolus, correct, okay? And then this one that doesn't go down so far, this one right here is the medial malleolus, okay? The thick bone here is the tibia, the thinner one is the fibula, the tibia, fibula, okay? What is this bone right here? Do you remember?
The talus.
Talus or astragalus. Very good. Now, there's a part, you can kind of see it a little bit. There's a part that's hanging down right here. It's on the posterior part of this. What is this called? The tibial, it means ceiling. It's a French word. That makes it even worse to remember, doesn't it? The tibial plafond, okay? The tibial plafond. If you break this, this, and this, what is that called?
Trimalleal.
Trimalleolar fracture. Very good. Very good. Okay. Okay, now we're looking at two knees, but they cut this off. The tech didn't do that. When they this wasn't collimated. This was, what's it called when you do it with the computer? Cropped it. They cropped it off. Okay. But okay, what do you think this is right here?
The patella.
It's the patella. That's right. Okay. Why is it so white? What's the matter? Is it dying? It's white because there's more bone, so there's more to get through, and it can't get through it, so it shows up white. Okay, it absorbs the x-rays. So this right here is the medial condyle. This is the lateral condyle, and I know because this is the lateral side. These are the condyles of the femur. These are the condyles of the tibia. And what is this right here? It's beautiful to see, nice and big. I love that. What is that? This is the tibial spine or intercondyloid eminence or medial or lateral intercondyloid tubercles. Okay. Now, this right here is the medial epicondyle, and that makes this the adductor tubercle. Okay, because that means if it's going to bring your leg back or add it to the body, then it's the adductor. Okay, what is this surface right here on the tibia? What is that? It's a flat surface on the bone. What is that called?
Patellar surface?
No, the patella's not there. That would be the tibial plateaus. Okay, plateau. That's a French word, Plateau. Remember I told you how the French are funny? EAU is O, plateau. Okay. These are the tibial plateaus. Now, what soft tissue structure is situated on these tibial plateaus that forms a cushion or a shock absorber? What are those called?
Meniscus.
The meniscus, right? Meniscus singular, menisci plural. Very good. Okay, let's look at the lateral. Okay, now you know how I love to complain about the positioning. Okay, this positioning is beautiful. The technique sucks, but the positioning is beautiful. Now, the reason why I said the technique sucks is this is too white. Okay, so they should have changed their technique for this. But here you see both of the condyles perfectly superimposed. You know, most people don't know how to do a knee. No matter how many times you tell them, they do it the way they want. They just lay it there. Okay, they don't position it. This right here, see this space, this patellofemoral joint space? Okay, this is, you're not supposed to see any bone in here. Lots of times when this is rotated, you got one of the condyles way over here. Okay, this is beautiful. This is beautiful. What is this right here? Same thing as this.
The intercondylar eminence.
Very good. Very good. Okay, now what is this right here? What is that?
The tibial tuberosity.
Very good. Very good. Now, I don't know. It looks like this, it either hasn't grown together, but it should have because I don't see any growth zones in this knee. But it looks like this might be separating. Can you guys kind of see that? Okay. But again, I don't know. I'm not a radiologist. It just doesn't look like totally normal right there. It could be, but it doesn't look like it. Okay, all this area behind the knee is called what?
Popliteal.
The popliteal surface. Okay, the popliteal, and so anytime you hear the word popliteal, they're talking about behind the knee. Okay. Okay, now here is a lateral that sucks. Okay, now do you remember? Okay, you see the space right here? Okay, do you see it right there? See or no?
No,
No. What can you know?
you can see part of the femur.
That's what you can scan. Look, here's one of the condyles. And here's the other condyle. So it's rotated, isn't it? Okay, and that's why we don't see that space right there because I'm sorry.
I'm sorry.
Oh, okay. All right. But anyway, so you should be able to see an empty space right there. Okay. And what is this right here?
Intercondyle eminence.
Okay, very good. Or tibial spine, correct. Okay, now the positioning, okay, this is supposed to come down kind of straight and this needs to be 45 degrees. So they just kind of slapped it there. Now this right here, this is a patella. Okay, this is the patella. Sunrise view, because it kind of looks like, look, the sun coming over the mountain. Okay, so this is the patella and this is the intercondylar sulcus. Okay. Okay, so the joints. Now, because again, you know, it doesn't have those little melting bones right there. Okay, the knee is considered bicondylar. Okay, now that just happened a couple years ago. So if you have the older edition of your Bontrager, it's calling it a hinge joint. So even though you have it in your book, it's going to get counted wrong because I'm telling you now. Okay. So if you have the new edition, it says it's bicondylar. And I don't know why they didn't do that to start with, because it's one joint, but it's got two condyles. Actually, it's got four condyles, right? But this is called a bicondylar joint. Okay. And of course, the proximal tib fib, the distal tib fib, and this is the ankle joint right here. Okay. Okay. Now this one, classification and mobility for joints of the lower limb. All joints except for the distal tib fib are synovial and diarthrodial. Okay. They're all synovial. Shoot. Synovial and diarthrodial. They're all freely movable except the distal tib fib, which is fibrous and only slightly movable. And that's only if you injure it. Okay. Now I remember when I was little, for many years, I used to ride on the back of my big brother's bicycle. And I was in the emergency room all the time because my feet and ankles would go into the spokes and I would stretch these out. Okay. So I always had injury to my distal tib fib all the time. Okay. Because well, let me just show you right here. Because this is not supposed to move. Okay. Except of course, with injury. So that's why it's only slightly movable. Okay, movement type, the IPs, what are those?
Gingliness?
I'm sorry?
Gingliness?
Ginglimus,
Or-
right? Okay, so those are ginglimus. Metatarso-phalangeal.
Ellipsoidal.
Actually, if it was metacarpophalangeal, they would be, but you don't really do this kind of stuff with your toes. Okay, so those would also be plain or gliding. Okay, you might see somewhere where it says that it's ellipsoidal, but it's not. Okay, intertarsal.
Plain.
Plain or gliding. Ankle. Remember, the ankle is only between the tibia and the talus. That would be a hinge. Okay. You think, oh, I can do other things. No, that's your foot doing it. It's not that joint. Okay. Femorotibial. We just learned that one.
Diarthrodial,
Yes, but we're talking about what is the movement type?
It's not hinge, is it?
No, we just said it wasn't. What is it?
A condylar?
It's bicondylar. That's right. That's right. Okay, what would the patellofemoral joint be? That would be plane or gliding. Okay, what about the proximal tibiofibular? I'm trying to figure it out from mine because I don't remember what that one is. We would have to look that one up. I think it's plane or gliding, but it might have a little bit of a twist going on there. So I have to look that one up and I'll tell you guys, okay? Because that one I'm not sure of. Why don't I just look it up right now? Just a second. Give me a second. What kind of joint is, which one are we doing? Proximal tibiofibular. Proximal tib fib. Let's see. It's a plane. That was correct. Okay. Yeah, it's the plane type. So it glides. Okay. Okay. The surfaces of your foot, we know that the top of your foot is the dorsum. The bottom of your foot is the plantar surface. The dorsum is also anterior. The plantar surface is also posterior. So if we're going to do an AP foot, we can also call it a DP foot for dorsopedis. Okay. No, I'm sorry. I said that wrong. I said that wrong. The dorsum is also known as the dorsum pedis, but a DP foot is a dorsoplantar. Okay. AP or dorsoplantar. And if we're doing it this way, which you may never ever do, this would be a PA or a PD, a plantodorsal. Okay. Inversion, varus, eversion, valgus. I think we talked about that on in the first unit. Okay. So sometimes people that have flat feet end out with this. Okay. It's called eversion. Okay. And this is inversion. I still think they named them wrong, but go figure. Okay. So another way to do this is think about the direction of the sole of the foot. So it's going in. So that's inversion. Eversion, the sole of the foot is going towards the exit. So that's eversion. Okay. Now, I can't help you with this one because I can't ever remember these and I don't want to. You guys have to though. So if you can figure a cool way to remember this, that would be great. And then I would share that. Okay. This is dorsiflexion and this is plantar flexion. Okay. I think they named these stupid too, but so be it. Okay. Okay. How many bones in the foot? How many bones in the foot?
27.
26.
Okay, so let's count. We have 14 phalanges in the foot. We have 5 metatarsals. So 14 and 5 is 19 plus 7 tarsals. So how much is that? I said 14 and 5, which is 19, and 7 is
26.
26. Okay. What is this one? Which of the following bones of the foot is fractured most often?
A.
I'm sorry?
A, the base of the fifth metatarsal.
That's right. The base of the fifth metatarsal. Okay. Which is the strongest and largest of the tarsal bones?
C.
Be the calcaneus, correct. What's the other name for the calcaneus? That would be os calcis, okay? Os calcis. I know you can't tell it, but I got a handwriting award when I was little. But it's not my fault, it's the mouse's fault. Okay. The sustentaculum tali is found on the I'm going to show you a picture. We didn't bring that up. It did. It did show it on the anatomy, but I didn't bring it up. But just a second, let me. Okay, let's start with this one right here. Okay. Okay. This right here is the sustentaculum tali, and it is on the calcaneus. Okay, it's on the calcaneus. Now let's look at this one right here. Okay, and you can see it's this. I don't have an arrow, but the top of this cross right here, it's right here. Okay. Okay, so, and what bone did we say it was on?
Calcaneus.
The calcaneus, there you go. Okay. The articular facets making up the tibial plateau slopes posteriorly at
10 to 20.
very good, very good. Okay. Another term for the patellar surface of the distal femur is the
Intercondylar sulcus.
very good, very good. Okay, the knee joint is classified as bicondylar, correct, correct. Okay, so we're gonna stop there. Now, next time we'll go through the positioning of lower extremities, but that part will go real fast, okay? And one good thing about the lower extremities is you won't be responsible for any cross section on the lower extremity, okay? So it's just regular radiographs on the lower extremity. But we'll go through the positioning. The positioning goes really fast on this. And then we will start part B, which would be the hip and pelvis. Okay? Okay. Was it okay that we all met this way today? Yeah? Okay.
Yes, ma'am.
Only one person came in, Brandon, huh?
Yeah.
Yeah, but I'm sorry about that. But anyway, so I will try and get this copied, and I will get it on my PCC as soon as I can. Okay. May not happen tonight though. Okay. All right. I will see some of you guys on Wednesday. Okay. Hope you guys had a nice Easter. Okay. Take care. Bye-bye.
Have a good day. Bye.
You too. Bye-bye.